Welcome back. Today we shall be talking about aspects related to the kidney, and I'll be explaining very baseline data to you, that is with respect to urine analysis. And the first thing that I'm going to explain here is aspects related to protein. You would notice that in a dipstick there would be 10 tests that can be done simultaneously, ranging from specific gravity to pH of urine to glucose, proteins, ketones, bilirubin presence, and multiple other things. But I would rather start with aspects related to proteins in the urine, because most of the time the questions are based on proteinuria written as 3 plus 4 plus. So let's try to knock some sense into what these terms basically mean. Well, first of all, we should be very clear that do we have proteins in urine of a normal person? The answer is a yes. And how much proteins are present in urine of a normal individual? Then the amount would be answered as less than 150 milligram on a daily basis. Once you get that right, then you are familiar with the fact that most of this protein would be rather constituted by tubules, because some of the protein is filtered by the glomerulus and some of that is coming by the tubules per se. When it comes to the glomerular proteinuria, or the glomerular component of the protein, then it is mainly albumin. The concentration of albumin will be less than 30 milligram in a 24-hour period, and the remaining protein will be coming from the tubules, that is going to be called as TAM horsefall protein. You would be aware from basic sciences that TAM horsefall protein, also called as uromodulin, is produced by the cells of the ascending limb of loop of Henle, and this will be constituting the remaining 120 milligrams. So that would be working out to a total data of 150, and obviously more than that would be called as proteinuria. Now you will notice that nowadays, instead of calculating the albumin component or the protein component, instead of collecting a 24-hour sample, we are taking a spot sample also. Why that is so is simply the convenience, because you see lots of time when you ask a person to collect urine for 24 hours, patients may not be collecting the entire 24-hour duration. There can be under collection, there can be over collection, and then you might have people who might say that I am not comfortable keeping urine in the premises of the house, I have a temple in my house, and a lot of various valid reasons. So now what we are doing is we are going in for a spot urine analysis, in which we are checking the albumin component in the urine, but the denominator in the expression will not be per day. Obviously, if it's a spot sample, it would be rather in grams of urinary creatinine. I'll specify this again. You see, what I'm saying is that if I want to calculate albumin excretion rate of a patient, because that will decide the significance of damage to the kidney. So albumin excretion rate can be expressed in two fashions. One is obviously a 24-hour sample. So in a 24-hour sample, the values would be given as milligram per day. But you will also notice that sometimes it will be written as milligrams per gram. Now what is this gram? This is gram of urinary creatinine. So what I'm saying is, we in the numerator are taking urinary albumin, and in the denominator we are taking urinary creatinine. So we can call it a urinary albumin creatinine ratio, or for that matter of fact, we can call it albumin excretion rate. It is AER. Two terms that I would like to highlight and can be written in questions are either AER of the patient is, he can give you a value, that is albumin excretion rate, or urinary albumin creatinine ratio. Either of the two basically are talking about the same thing. They're just different expressions, either in milligram per day or in gram of urinary creatinine. Now, normal person will be having less than 30 milligram of albumin per day or per gram of urinary creatinine in a spot sample. If you find that it is written in a multiple choice question that patient is having 30 to 300 milligram of albumin present per gram of urinary creatinine, then you will say that the patient is having a moderately increased albuminuria. Mark my words there. The technical term is moderately increased albuminuria. And this is one of the prime reasons why I am saying this or teaching you, because you see, to your senior batch, I had taught the term microalbuminuria. But currently what they have done is that in the current edition of Harrison, they have removed the word microalbuminuria, and rather they are using the word moderately increased albuminuria. So I'm just putting a line over it and telling you the fact that lots of time I might use the term microalbuminuria, especially if I'm using data of the previous years, or especially if you have to solve questions of the previous years. Microalbuminuria familiarity should be with you, because you all have read diabetic nephropathy presents as microalbuminuria. Screening test for diabetic nephropathy is microalbuminuria. So you just need to keep in mind the new term, that is moderately increased albuminuria. Moving ahead. If you are going to read that the amount of albumin is between 300 to 3500 milligram per gram of urinary creatinine, this would mean that the patient is having severely increased albuminuria. The older term that was being used for this was macroalbuminuria. So we used to study micro and macroalbuminuria. Now those terms are no more used, and rather the terminology is changed into English version only: moderately increased and severely increased albuminuria. If the concentration of protein in the urine is more than 3.5 grams, you can very well understand that we are talking about nephrotic range proteinuria. And in cases of amyloidosis, etc., it might go up to even 4 grams. While I have written this data before you, I just put up a question. Can you tell me a condition where you can get about 10 grams of urinary protein? Remember, the total serum protein is 6 to 8 grams. We have albumin, we have globulin. Total serum protein is 6 to 8 grams. And my question is, do you know a condition where you can have 10 grams of protein in urine on a daily basis? Well, the answer to that would be multiple myeloma. Multiple myeloma is characterized by Bernstein's proteins. You all know about paraproteins, the incomplete light chains that are produced, or positively charged proteins that are present. So paraproteinuria or multiple myeloma can be having up to 10 grams, because obviously there is a overproduction of proteins in the body. So you would have read about this term, overload proteinuria. Overload proteinuria simply means that there is excess amount of proteins in the blood and therefore they're coming in the urine. One of the reasons for overload proteinuria that you have to remember from MCQ perspective is what I just said right now: a disease in old age which is related to tumor of the plasma cells called as multiple myeloma. Apart from this, even when it comes to rhabdomyolysis can contribute to myoglobinuria, or there could be massive hemolysis contributing to hemoglobinuria. Like in case of a mismatched blood transfusion, there could be hemoglobinuria due to type 2 hypersensitivity. So the term used would be mainly said as overload proteinuria, that you should be aware of. Functional proteinuria is another term that you will read sometimes in books. Functional proteinuria just means the fact that there is no organic kidney cause per se. It could be present secondary to, let me say, person has done jogging in the morning. You see, lots of time you will see that people might come to the lab after doing a morning run. Now, after a morning run, if a person is going to deliver a urine sample, there's a possibility that RBCs could be present in the urine and even proteins could be present in the urine. So especially when you are testing for proteins and you are checking for RBCs in the urine, you can tell the patient to avoid physical exercise for at least a week before the testing is done properly, because lots of time you might be having false positive reports coming up. Like a person is having 500 milligram of protein in urine on daily basis per gram of urinary creatinine, he would come in the category of moderately increased albuminuria, whereas this guy is not having a kidney disease. It's strenuous physical exercise that has resulted in that. If a patient is having a genuine proteinuria, you will also notice a person complaining of the following fact, and you can see here that the patient is having a presence of a foamy urine. Now, what I'm saying is, and you would have noticed also, that first morning urine sample can also be a little foamy, but then the foam would settle down in a while. But in this case, you can see that the urine was kept. You can see the change in the color of the urine. It has become more dark. In fact, I can just state one more question here. Why does the urine change color on standing? Like you can see that urine, when it is freshly passed, it is colorless. And when you keep the urine on exposure to air, the urine becomes relatively darker. Well, what is present in urine? What is present in urine that would make the urine appear relatively more yellow than what is present in urine of normal people is urochromes, and urochromes cause a change in the color of the urine, in a sense that the urine will become relatively more darker. I repeat my statement: freshly passed urine can be colorless, but then the urine will become relatively more darker. I would say that is because of urochromes. Urochromes are a normal constituent of the urine. Apart from this, foamy urine is definitely a feature that you will encounter with respect to patients of proteinuria. So especially, when I would say a mother of a child comes to you and she says, "Doc, my child is having this foamy urine," you might just dismiss her off casually, and then you find that the same child after 2 days has been brought with pedal edema and puffy eyes, and the child can't even open his eyes because minimal chain disease will cause a nephrotic range proteinuria. And well, the mother was right; she was noticing a foamy urine, which you thought maybe was an infection, whereas it was an early presentation of minimal chain disease, which is one of the common causes of nephrotic in pediatric population. We shall now be talking about causes which are responsible for moderate increase of albuminuria. This was formerly called as microalbuminuria. The first point to be remembered by you is that people who are having this will be having higher cardiovascular mortality. The incidence of coronary artery disease is significantly increased in these patients. One of the reasons why this could be present is diabetes mellitus. Do remember the fact that patients with diabetes mellitus, if they're type 1, it will take 5 years. If they're type 2, it will take 20 years for them to develop nephropathy. Now, only people with HbA1c more than 7% of the ones who are going to end up with development of a nephropathy. But once nephropathy will develop, if we want to identify that yes, it is occurring, then check for moderately increased albuminuria. That is, check for either 24-hour urine, or in the spot sample, check for the albumin concentration. And if it turns out to be between 30 to 300, as I told you, that means the kidneys are already damaged in the patient, and we need to start low dose ACE inhibitors to slow the progression of damage to the kidney. The second reason why this would be happening is hypertension, and even patients of glomerulonephritis of various etiologies, the early presentation of glomerulonephritis of various etiologies can be a moderately increased albuminuria. Now, why would you be having a severely increased albuminuria in a patient? This would mean that the values would be in the range of about 300 to 3500 milligram. The first and the foremost would be answered as the same data that I mentioned on the left hand side: diabetes, hypertension, glomerulonephritis. Over and above this, I would like you to remember it could be early presentation of myeloma or monoclonal gammopathy of unknown significance initially, which is the lower version of multiple myeloma, I would say, can present as the same. Then is heart failure, fever. Exercise can also contribute to this presentation. So we obviously have to keep that at the lower part of the discussion, because we can call this as a diagnosis of exclusion. If all other causes are ruled out, then possibly the person was doing a hard physical exercise before delivering the sample to the hospital. And I can then make a very peculiar terminology, or state a very peculiar terminology before you, that is called as postural proteinuria. Now, this is very surprising if you're reading for first time, that these people will be having protein in the urine when they stand. And when they lie supine, the proteinuria disappears. So what do we do in these people? We collect the urine of these patients when they are supine, and then check the urine when they're standing, and we find that there is a marked difference in the protein component, which can be pretty substantial. I mean, more than 300 milligram present. So this is obviously a diagnosis of exclusion, and the common causes have to be ruled out. However, in some questions, they might trouble you by saying causes responsible for nephrotic range proteinuria. Now, the first answer that I usually get when I ask this in a routine class, face-to-face interaction, cause of nephrotic range proteinuria, the first answer that I usually get is minimal chain disease. But I don't want you to answer that, because the first and the important reason to be answered for this is diabetes mellitus, then is amyloidosis, and then comes minimal chain disease. So we are talking about here not nephrotic syndrome, I'm saying nephrotic range proteinuria. So when that word comes up, don't straight away jump the gun and start talking about minimal chain disease. You have to think in terms of first diabetes, amyloidosis, then minimal chain disease in a patient. In fact, the most common organ involved in amyloidosis happens to be the kidney, and you can get a nephrotic range proteinuria. I mean, that's the MCQ statement that you read in pathology. Commonest organ involved in amyloidosis is kidney, and you can get bilateral enlarged kidneys, and you can get nephrotic range proteinuria and amyloidosis. Other causes for this can be FSGS, focal segmental glomerulosclerosis in adult population, and then MGN in geriatric population. But here I would just like to repeat my statement, what I said. If you read the word nephrotic range proteinuria, don't straight away jump the gun and answer it as the minimal chain disease. You have to first answer as diabetes, amyloidosis, minimal chain disease. You would have also encountered multiple choice questions where he is not talking about the latest aspect of albumin excretion rate. Rather, he is still talking about proteinuria 2+ and 3+. So to solve those old MCQs where albumin excretion rate is not given, we also need to study some baseline information with respect to what do we mean by how much protein is present, rather, when you say that protein is trace, or for that matter of fact 1+, 2+, 3+, and 4+. So just try to remember the mathematical values that I say before you for trace proteinuria versus 1+. Trace is when the concentration of albumin is 15 to 30 milligram per deciliter, and I usually find most people are able to recall that and remember it because the value of upper limit is same 30. As I told you right in the beginning, 30 albumin can be coming in urine of a normal person. 1+ is 30 to 100. Now this is not 30 to 300, it is 30 to 100 milligram per deciliter. 2 plus protein would be 100 to 300 milligram per deciliter. So now we are hitting the upper limit, upper circuit of when I was saying that the person is having moderately increased albuminuria, that is upper circuit of 300 going up to 3500. 3 plus, however, goes up from not 3500, but this is up to 1 gram, which would be written here for uniformity purpose as 1000 milligram, and 4 plus would be more than 1 gram of protein in the urine per deciliter. So one, I want you to remember these dipstick values also, which can be isolated question by itself or could just increase your comfort level, especially when you're solving the relatively older questions which are related to protein loss present in an individual. But most of the questions that will come from now onwards will be related to the current terminologies. Moderately increased albuminuria, that would be 300 to 3500. Severely increased would be more than 3500, and yeah, obviously reaching up to nephrotic range proteinuria. But these are the terminologies that they are using, so that is why I have explained this to you. We will now move on to the second part related to evaluation of the urine, and that is aspects related to hematuria. So when do we say that the patient is having a significant hematuria or he is having a persistent hematuria? There has to be a cutoff present, and in the very first place we also need to know that do we have RBCs in urine of a normal person? Well, the answer is a yes. We do have RBCs in urine of a normal person. When would we say that the hematuria is significant or is persistent is the objective of this discussion and was also the question. Then remember the fact that if it is more than 3 red blood cells which are present per high power field of a centrifuge specimen. I'm not saying that you're taking a fresh specimen and you look under a microscope, you will see 3 RBCs. It is in a centrifuge specimen. If you are able to demonstrate this particular cutoff, that implies that yes, it is a presentation of a hematuria, and it is not one sample, it is at least 3 times that you are able to demonstrate this on 3 different occasions, ideally separated by 1 week gap. So this week, the next week, and the next week, if at least 3 times at an interval of 1 week, I can demonstrate that the patient is having this cutoff of 3 RBCs or higher present, that means the fact that the patient is having a significant or a persistent hematuria. An important cause of that is IgA nephropathy, where person can be having lifelong microscopic hematuria. Another definition is more than 100 RBCs in a single sample. 100 RBCs per high power field in a single sample, or more than 3, at least 3 times over 1 week, are the 2 definitions of significant or persistent hematuria. Here I would also like to quote the fact that some books are mentioning 5, but that in 5 it is per microliter of urine. It's not, a denominator is not high power field, it is the denominator is an rather microliter, and here it is per high power field. So if you cast a glance at this image that I have shown before you, you will notice that in the slide a lot of RBCs are found in the urine sample. You will notice that some of the RBCs are having a very normal shape, but some of the red blood cells are having rather an irregular surface, that is referred as acanthocytes or are called as dysmorphic RBCs. So after knowing the definition of significant and persistent hematuria, the next thing that I want you to remember is dysmorphic RBCs are diagnostic of. Because the RBCs are coming by the glomerulus, they have to filter through the layers, so there's a change in the physical appearance of the RBCs. Dysmorphic RBCs are always suggestive or diagnostic of glomerular bleeding, and to that if you add the word RBC casts, the diagnosis becomes even more clear. So lot of MCQs, because they say this word dysmorphic RBC, you straight away know that it is a glomerular pathology occurring in a person. Now, if a person is having gross hematuria, it's like the first episode or maybe a second episode that has happened in the span of previous 2 or 3 days. A gross hematuria, the first thought process of yours should be urological cause. It could be kidney stones, it could be bladder stones, it could be bladder cancer. Once the urological causes have been physically ruled out or have been ruled out on basis of investigations, should you think in terms of renal parenchymal causes, that is like glomerulonephritis, and lastly you should also think in terms of hemolysis. Look at the stark contrast in the 2 statements that I'm making before you. In one, I have said that if a person is having microscopic hematuria detected on annual medical checkup and is persisting every 3 months, every 6 months on a follow-up, it is still persisting, or it might be increasing or decreasing by few digits, it is Burgess disease or immunoglobulin A nephropathy. But if a person is having a gross hematuria, then the first thought process of yours is not a parenchymal disorder of the kidney, not a glomerular disease, but to think in terms of urological possibilities. So suppose in the exam, he gives you a question in which he is mentioning that the patient is having blood in the urine or he is having a passage of a red color urine, and the doctor has done a dipstick evaluation of the urine sample of the patient, which is turning out to be positive for hematuria. Please appreciate the fact that dipstick can be false positive. It can tell you that there is a hematuria, whereas actually the patient could be having myoglobinuria or he could be having hemoglobinuria. So how would you differentiate is the basic objective of the discussion, or what is the limitation of the dipstick is what I am trying to explain to you. The question will now say, what is the next best investigation to be performed in this particular case? Then your answer would be given as that you will spin the urine sample or centrifuge the urine sample and evaluate the supernatant. Let us see what happens. I said I will centrifuge the urine specimen of this patient, the same one which is false positive for hematuria. I don't know at the moment it is false positive or not. I'm just assuming that it could be false positive. So I have taken the same sample and for a duration of 5 minutes, I have spun it at 1500 RPM. Now, there are two possibilities with respect to the color of the supernatant that would help you identify the etiology. One possibility is that the supernatant has become totally clear. Why? Because when you spin the sample and it was having RBCs, the RBCs will settle due to the centrifugal force to the bottom, and this means that this was a genuine case of a hematuria. On the other hand, if the supernatant will remain red in color or reddish and brown in color, that means the fact that it was not having RBCs but was rather having either myoglobin or was having hemoglobin. Now, how would you differentiate whether the patient is having hemoglobinuria or myoglobinuria? Well, myoglobinuria has a half-life of about 3 to 4 hours. So you will notice the fact that myoglobin per se, or the myoglobinuria in the specimen, if you keep it after about 3 hours or so, this sample will also become clear because myoglobin will gradually disintegrate. Whereas in case of hemoglobinuria, since it will not disintegrate, the sample will remain of the same size, and therefore I have told you a limitation of a dipstick method with respect to a hematuria. In the same breath, I can also use this opportunity to mention the fact that dipstick can also be not very accurate with respect to proteinuria. You see, I described dipstick in the later part of proteinuria rather than starting with it, because normally when we attend a class in medical college, they usually start with a dipstick, and I did ulta or opposite, because what is asked nowadays or what is the convention nowadays is that dipstick is less accurate as compared to the albumin excretion rate. So we should ideally start by checking for albumin excretion rate in a patient. But what is the limitation with respect to a dipstick for proteinuria is that do remember the fact that this dipstick that I have just described for proteinuria, this can detect only albumin. It cannot detect positively charged proteins. It cannot identify paraproteins. So there is lots of time a possibility that you might be having a patient of multiple myeloma. The total protein in the urine of the person is 8 grams, 10 grams, and dipstick is negative in the patient. Why? Because the dipstick is designed to pick up negatively charged protein albumin, and it cannot identify positively charged proteins of multiple myeloma, that is paraproteins. That's one of the big limitations that you have with the dipstick. Another possibility can be it can be false positive with respect to if the patient is having a urinary pH which is on the higher side, or the urine sample is very highly concentrated. You see, normally urine is acidic, 4.5 approximately. If it is an alkaline urine, it could be false positive dipstick in a patient. So dipstick is good for screening. It is one of the methods that you obviously use in your words. It will tell you that, okay, there's a problem, but then you cannot be 100% sure. So you need to do more specific tests so that identification of the cause can be made. Since I'm describing hematuria before you, it also becomes imperative for me to highlight the following algorithm, which is that if a person is having hematuria and simultaneously in the question it is mentioned that he's having pyuria or bacteriuria, then it means the fact that he is not having a glomerular disorder but is rather having an infection. So this is usually a presentation of pyelonephritis or complicated UTI. But if you read a question that is going to talk about hematuria, then is going to talk about red blood cell casts. RBC cast will be formed because RBCs will go and stick on the top of the TAM phosphoprotein. So we call it RBC casts. Or he mentions the word dysmorphic RBCs. that is crenated RBCs or acanthocytes. Either of the two can be written. Along with this, proteinuria could also be given in the question, because when it comes to glomerulonephritis, then glomerulonephritis of various etiologies can also be having proteinuria. The magnitude of proteinuria in this case would be something like 500 milligram per day. That would be something like 2 plus proteinuria present, or 1 to 2 plus proteinuria present in a patient. So both of these have to be kept in mind while evaluating questions. I shall now be describing to you a parasitic cause responsible for hematuria, which is schistosomiasis. It is rather two main reasons why we are discussing it apart from hematuria. One, it will cause a development of fever, which has a very peculiar name, that is called as Katayama fever. And the second reason is the physical appearance of the egg of schistosomiasis that was asked in the exam. So I'll just show that image to you quickly, though it's a cross subject image and you know it from microbiology, that the egg of schistosomiasis will be having a terminal spine. You can remember it as TSH. T would stand for terminal spine. That would be found with respect to egg of S. schistosoma hematobium. So TSH as a mnemonic can be used. Do remember the fact that do not answer eosinophils in the urine for schistosomiasis. Answer as hematuria responsible for it. In schistosomiasis, there would be presence of eosinophils in the blood. Eosinophils in the blood and hematuria as a presentation. Why am I highlighting that is because you can be getting question regarding presence of eosinophils in the urine. The statement of mine is eosinophiluria. Normally we have eosinophils in the blood with parasitic infestations, but eosinophiluria is again a terminology that I want you to remember. And in fact, straight hitting the MCQ, if you read eosinophils in the urine, don't answer schistosomiasis. It will be having eosinophils in the blood with hematuria. If you read eosinophiluria, you have to think in terms of two possibilities which have been described in the subsequent lectures, that is atherombotic kidney disease. This is a complication that is seen with coronary angiography. And the second cause for this to be remembered is easier to remember, that is allergic interstitial nephritis. So I repeat my statement that I want you to remember. One would be that if he says eosinophils in the blood and there is a hematuria, then it is schistosomiasis. But if you read about eosinophiluria, it is atherombotic kidney disease and allergic interstitial nephritis. The next thing that I would like to bring to your notice with respect to this particular image is that this is not RBCs in the urine, because if there are RBCs, they would be of equal size. Here you can see the marked disparity in the size of these rounded droplets that you are seeing. So what is present here is not red blood cells, but is rather presence of fat droplets. Now it looks very surprising to read fat droplets in the urine, and we are studying it because we just spoke about RBCs and eosinophils in the urine. So we need to next study regarding fat droplets in the urine. These would be referred in multiple choice question as oval fat bodies. Then the first important cause for oval fat bodies to be remembered by you is nephrotic syndrome. And why is that so? Because in nephrotic we have hyperlipidemia, there is increased cholesterol, increased triglycerides, and anyway nephrotic patients have increased cardiovascular risk also. So nephrotic syndrome is because lipids are more in the blood, they can come in the urine also. The second time in medical literature when you will read this surprising term of fat in the urine is fat embolism. And another cause to be remembered is chyluria, that is a parasitic infestation causing this manifestation, that is filariasis. Three important aspects that I want you to remember from urine analysis perspective is one, eosinophils in the urine, then is oval fat bodies, and the third very atypical thing that they've asked is with respect to polarized microscope being used to evaluate the urine of the patient, and the lesion that they have asked here is called as Maltese cross appearance in the urine examination with respect to polarized microscopy. Maltese cross appearance is read by us multiple times. One, we read about Maltese cross appearance even in the bloodstream. So in the peripheral blood smear, if you're reading about Maltese cross appearance, then you know that it is babesiosis, Babesia microti. You can see this cross appearance inside the red blood cells of the patient. So the same question asked for peripheral smear, and the similar language of the question asked for urine examination. So we need to remember both of them. First to remember, for Peripheral smear is Babesia microti. It's a differential diagnosis of malaria. It's an intracellular parasite which is, however, transmitted by heart attack. That is ixoidus. That's the vector for it. That's again a question. In the NEET exam, they gave an image like this. They did not ask what is the slide showing. They said what is the vector responsible for this. That is ixoidus. Maltese cross appearance in a urine examination with respect to polarized microscopic findings should be remembered as Fabry's disease. This would be a lysosomal storage disorder which is related to a defective enzyme that is called as alpha galactosidase A. The gene involved in this condition would be called as GNA gene. You can skip the gene part, but at least remember that Maltese cross appearance is asked total of 3 times. One is in front of you, urine, polarized microscope Fabry's. For peripheral smear is Babesia microti. And if the same question is asked for Maltese cross appearance for CSF, then you have to answer an organism which is taught to you as a cause of meningitis in a AIDS positive patient, that is Cryptococcus neoformans is responsible. So these are 3 aspects to be remembered. We will now talk regarding more conventional stuff, because the dipstick will also evaluate the urine specific gravity for you. So normal urine specific gravity hovers between 1.020 to 0.030. This fluctuation of specific gravity of the urine is mainly thanks to the concentration mechanisms which are working in the kidney. However, sometimes you could be having patients where the ability to perform this function will be lost. You see, one of the basic functions of the tubules of the kidney is to concentrate the urine or to dilute the urine. So isothinuria basically means that the specific gravity of the patient does not change. It remains constant. The specific gravity of urine is going to remain equivalent to that of the specific gravity of plasma. So therefore, specific gravity of plasma is 1.010 and it is of urine 0.20 to 0.30. So isothinuria is defined as inability to concentrate and dilute the urine, and the specific gravity is same as that of plasma. Now, when would this be happening in a patient? Then your answer would be given as chronic tubulointerstitial disorders. Why? Because as I explained, tubules are responsible for concentration and dilution of the sample. If they are damaged, well, this manifestation would occur in the patient. Another advantage of checking out the specific gravity is that it will help you in differentiating the pre-renal cause of acute kidney injury versus the renal cause. Because if a person is having a renal cause, let me say his tubules are damaged, then in those circumstances, the ability to concentrate and dilute would be lost. Whereas in pre-renal cause, the tubules are functioning fine, so ability to concentrate will be there. So you will notice the fact that in pre-renal variety of renal failure, acute kidney injury, the urine concentration would be on the higher side as compared to the concentration of the renal cause, which would be on the lower side, because ability to perform this function would be lost. The next point to be remembered is regarding the pH of the urine, and normal pH of the urine hovers between 4 to 4.5. In case you get a question in which person is having alkaline urine, like for example he says person is having pH which is constantly more than 5.5, then there are 2 possibilities why this could be happening. One could be a disease of the proximal tubule which is responsible for reabsorption of bicarbonate. So if this reabsorption of bicarbonate is lost, then person will have bicarbonaturia. Bicarbonaturia means that alkali is lost from the body, so there would be alkaline urine because alkali is getting lost in the urine. This would be called as renal tubular acidosis type 2, where the function of the kidney with respect to reabsorption of bicarbonate is lost. So the technical word is bicarbonaturia. In fact, I specifically want you to remember this word bicarbonaturia because you don't read it anywhere else. Second, distal converted tubule is responsible for excretion of hydrogens. If it is damaged, then the technical problem in the patient will be inability to excrete protons. We can next talk about color of the urine, where it can give you flashy color like pink. Now this would be seen with the iron chelator, that is deferoxamine. However, there is an alternative terminology which I also want you to remember, that is pink diaper syndrome. This is because of infection with a bacteria by the name of Serratia macerans, which gives a pink color to the urine, and it stains the nappies of the child or stains the diaper of the child, so called as pink diaper syndrome. Then another color to be remembered would be red discoloration of urine. For red discoloration, do not answer rifampicin, because rifampicin causes a orange discoloration of the urine. You will rather answer a drug that will cause a red discoloration of even tears and even possibly saliva and then of the urine of the patient, that is clofazimine. Then it can be seen with porphyria. It can be seen with myoglobinuria, that is crush syndrome in a patient, and obviously gross hematuria in a patient. Cola color urine is specific for hematuria, and I have already explained to you the fact that if you will centrifuge the urine specimen of the person, the supernatant will always become relatively clear. Then is patient passing a black color urine. Now black color urine could either be a presentation of hemoglobinuria, like paroxysmal cold hemoglobinuria, paroxysmal nocturnal hemoglobinuria. But if he says the word black on air exposure, then you very well know the answer. It would be given as alkaptonuria, which is deficiency of homogenesic acid oxidase. In these patients, he has asked how would you prevent the urine from turning black on exposure to air. Then we can give vitamin C for management of patients of alkaptonuria. Though the main treatment for alkaptonuria is nitistone, but vitamin C can prevent the urine from turning black in these patients and reduce the discomfort of these patients. And then we will talk about casts. One on the left hand side of the board, you can notice the RBC casts which have been shown here, which are a feature that is seen with acute glomerulonephritis. However, he has asked about WBC casts, which are seen with pyelonephritis. Now, because that is very easy for anybody to answer, acute pyelonephritis or chronic pyelonephritis can be having WBC cast. So, a condition apart from pyelonephritis that can have WBC cast is acute interstitial nephritis. Do remember the fact that hyaline casts are a normal constituent of urine and they do not signify anything abnormal, and the casts are mainly composed of TAM phosphoprotein. But if a person is having problem in his glomerulus, like in this diagram, I have tried to show this is the surface area of the glomerulus, the basement membrane is damaged. Therefore, the RBCs would leak from the top and they would come and stick on the surface of the TAM phosphoprotein. Let me say this is the TAM phosphoprotein produced by the ascending limb of loop of Henle. You can see here red blood cells leaking from the top, and they would travel all the way and come on the surface of the TAM phosphoprotein responsible for creation of what I said superiorly, that is presence of a RBC cast in a patient. The next on the agenda to be remembered is broadcasts. Broadcasts are found in CKD. Do not answer chronic glomerulonephritis, chronic kidney disease. Why broadcasts are found is because in CKD most of the kidneys are damaged, tubules are damaged. So whatever are the remaining tubules, they will try to take over the function of the damaged tubule. So therefore, the term is dilated casts or broadcasts are a feature seen with chronic kidney disease in a patient. The last terminology to be remembered is muddy brown cast. This is a feature that is seen with acute tubular necrosis, that is a pre-renal variety of renal failure. The reason why we have studied these baseline details is mainly to get sensitized to all these terminologies that will give you insight or will rather let you know which part or compartment of the kidney is involved. So most of the time if a question begins with like let me say begins by saying RBC cast, dysmorphic RBCs, you know glomerulus is involved. If he begins by saying eumorphic RBCs, he says himself eumorphic, no change in the shape of RBCs, then it could be a urological cause, it could be stones in a patient that could be responsible for hematuria. So we can compartmentalize the areas of the damage in the kidney by evaluating all these informations that I have explained to you. So especially of interest of mine for the main reason I would say, one, I would like you to remember these terms, eosinophiluria, then is Maltese cross appearance or oval fat bodies. And the next agenda that I want you to remember from this discussion that I've had before you is that microalbuminuria term is now not used and we use the term moderately increased albuminuria, and one of the important causes for this is diabetes mellitus, and even for nephrotic range proteinuria, surprisingly the leading cause is diabetes mellitus, then is obviously the remaining causes that I've explained to you. So these are the aspects to be remembered here, guys. Keep focusing, keep learning, and every day for you is like a new day where new facts have to be learned, and knowledge is power, right? So keep accumulating that knowledge.